I completely agree. I think the trials that are presented at ESC, they have immense impact on our, daily practice of cardiology. But also, I must say that I enjoy the other side, which is meeting colleagues across the world and kind of seeing, how cardiology is practiced in different parts of world. How the training of cardiology goes and how their early career is shaped and what struggles and challenges they go through.
When saving lives is what you do, your standards are anything but standard. In fact, you set them higher than most to deliver results that patients can depend on. You refuse to compromise. We couldn't agree more. We are Edwards Life Sciences, and like you, we believe that good is never good enough. Rising to the challenge of today's TAVR patients isn't just a mission, it's a commitment. And because you set a higher standard, we set our sights on meeting you there. Welcome to the higher standard, your standard. Learn more at edwardstavr.com.
You're listening to Parallax from Radcliffe Cardiology in association with makeadent.org. Here is your host, Ankur Kalra, MD from the Cleveland Clinic.
Hello, everyone. Welcome to another episode of Parallax. So this one, is a special episode based on what has just happened this past weekend at the European Society of Cardiology Congress. To me, ESC always is a blockbuster because so much good science, so much great science rather is presented at this forum, and multiple papers come out within a span of a weekend. And then, for me, it just takes me over a month to just absorb everything, slowly read the fine print and the details. So I've asked for help from a really good friend of mine. We've known each other for many years, and actually have been wanting her to come to Parallax as a guest. And, we'll have that episode at some point this year or next year. But the focus of this episode is not the personal journey of Dr. Purvi Parwani, which I know is going to be very interesting. But, here she is sort of helping me out with all the knowledge that has come out of ESC, sort of to digest that and sort of imbibe that and inculcate that in our daily practice. So without much further ado, I'm going to introduce Dr. Parwani. Dr. Purvi Parwani is a consultant cardiologist with a focus on advanced multimodality imaging. I'm sure all of us who are listening to this episode know how passionate she is about imaging, through her dissemination of knowledge and information on various social media accounts. And she is assistant professor of medicine at Loma Linda University Health in Loma Linda, California. Purvi, welcome on the show, and thank you so much for doing this for me on such a short notice. I really appreciate it.
Thank you, Ankur. It's such an honor to be here. And I know we had been wanting to do this for a long time. So I'm so glad that here we are together and I got this chance to do it with you. So thank you again for inviting.
Oh, no, the pleasure is mine. And, I've enjoyed your journey through the years. And I've always learned immensely from everything you've shared on social media, whether it's your amazing recipes of vegetarian food, or, whether it's imaging with MRI and echo, or whether it's on new trials. And I think that's a good segue into talking about ESC, because as I was mentioning earlier, ESC is sort of the highlight conference for me for the year, and it sort of has been for many years, because somehow ESC manages to get, I think, arguably the best trials that change the face of how we practice cardiology. That's at least my opinion. But I'd like you to share more on what you think about ESC, and then sort of start getting into trials that we're going to talk about today.
Yeah, no, I think I agree with you. I think, I had not been to ESC before because of my visa issues when I was training to be a cardiologist. But since I've been attending, I've attended every single ESC. And, it's kind of that bolus of cardiology knowledge that comes at you. And, of course, I think I completely agree. I think the trials that are presented at ESC, they have immense impact on our, daily practice of cardiology. But also, I must say that I enjoy the other side, which is meeting colleagues across the world and kind of seeing, how cardiology is practiced in different parts of world. How the training of cardiology goes and how their early career is shaped and what struggles and challenges they go through. So I think in last, 3 years, actually 2 years that I attended, last year was virtual and so is this year. I think in those 2 years, I developed some really good relationships with friends across the world. And of course, the science that the conference brings is undoubtedly the best. So I think I actually, believe it or not, we still get meeting days. And I actually took 2 meeting days to kind of sit down and, just go through all the science. And it was at odd times. And I stayed up and, bit jet-lagged and still catching up on my sleep schedule. But, there's just so much to learn. And I'm still listening to so many, other sessions that happened that I wasn't able to catch, live. So completely agree with you there. And I just cannot wait to be back at ESC next year in Barcelona. And I hope that you come.
Yeah, no, Barcelona is special to me because that was the first time I presented a late breaker at a meeting, of the magnitude of ESC, and happened to be in Barcelona in 2017. Also happened to be the year when we had our first boy. So, I vividly remember Barcelona for many reasons. So Purvi, jumping right on, let's start off with the first trial that you want to talk about, which was presented and published, I believe, in the New England Journal of Medicine. And that is about salt substitute in diet and its effect on blood pressure and also mortality. So do you want to just talk to us a little bit and the listenership about, what the design of the trial was and what were they trying to study, and sort of what are the take-home messages and how it will impact your practice of medicine and cardiology?
Yeah, of course. Thank you. So I think when we look at the public health impact, this was probably my most favorite trial out of ESC. They took, it's called the Salt Substitute and Stroke Study, SSaSS, and basically they took almost 21,000 patients from 600 villages in rural China. And these patients either, had history of stroke or they had history of hypertension. In fact, 73%, I think, had CVA and 88% hypertensive. I think the mean age was 65 and almost half of them were women. And they followed these patients for 5 years. They randomly assigned them 1-to-1 ratio to the interventional group, which included, patients on or participants on salt substitute. And this salt substitute was 75% sodium chloride and 25% potassium chloride. And then the control group, which was regular salt, which is 100% sodium chloride. And the primary outcome was stroke. And the secondary outcome was major adverse cardiovascular events and death from any cause. And of course, there was a safety outcome of, clinical hyperkalemia. So I think through pure study, I think we have known that, increasing potassium and, decreasing sodium has, impact on the events, cardiovascular events. And But it was an observational study, and it wasn't very clear exactly what matters. So traditionally, if we look at the guidelines recommend low salt, but that is due to major impact on the blood pressure, which in turn has impact on cardiovascular outcome. And I think this was this was the study where they designed this study to kind of understand what impact the salt has directly on the outcomes. And I think the outcomes, the results are spectacular. So at the end of 5 years, they saw that risk of stroke was lower with the salt substitute than with the regular salt. This reduced risk of stroke was almost 14%. Major cardiovascular events went down to almost 13%. And also there was like this crazy decrease in all-cause mortality by 12%. So I think that, along with that, the safety outcomes, as I was mentioning, the hyperkalemia was not significantly higher with the salt substitute compared to the regular salt. Now, granted, they did not measure potassium in patients, but I think they went to, they really studied, every single participant and made sure that patients were not admitted for hyperkalemia, or there was no sudden cardiac death due to hyperkalemia, in either of the arms. So the conclusion of the study was that amongst the patients or person who had history of stroke or older than 60 years and had history of hypertension, the rate of stroke, major cardiovascular events, and death were lower with a salt substitute than with regular salt. So I think that, of course, it's a spectacular study because, salt is the essence of flavor, right? And I think if we look at the baseline salt consumption in Chinese population, it's almost 4.3 grams. Now, what's very interesting here is that if we look at world, as a whole, I think almost 5 billion world population uses 50% of salt, through a dietary salt, by using it in cooking or seasoning, or preserving the food. But then you have Western countries like United States where, a lot of salt comes from the processed food. So I think that's where, one of the things is how generalizable this would be in the population where the dietary salt predominantly comes from the processed food, not from the, salt that is regularly used in the food through cooking. But I'd argue actually that actually makes me excited because if, the government of various countries, partner with the industry, this can be, really good marketing point for the industry, for the food industry, where if they substitute, sodium chloride to this mixture of potassium and sodium chloride, I think I see it as a marketing opportunity because now you have a large trial showing clear benefit. The other, kind of pathophysiological question everyone is asking is it truly the reduction of the sodium or is it the increase in the potassium? And this is, because there have been studies showing that increasing potassium, does help cardiovascular events. And, that brings me to the next point because, salt substitute, there are variety of salt substitute and, not all the salt substitute are the same with, 25% of potassium chloride. So we just don't know how this will plan out with other substitute, but at least we have one agent that at least has shown efficacy now. And then, as we were discussing this on social media, one of my friends who's not in medicine asked me, so are you going to change this? And, that's another thing. Like, if you look at this population, this was a higher risk population, almost 70% with CVA, 88% with hypertension. So if you take younger population or the one, without any history of hypertension, what's the applicability of this study in our patients, right? So I think take-home points. I think that if you have a patient who has history of resistant hypertension and particularly struggling with really bad cardiovascular events in life, I think I definitely suggest them to use a salt substitute. There was a question about taste. How does it taste? And I actually, Ankur, have used salt substitute. It's not that bad. And I think that if 21,000 patients, half of them were able to tolerate it, I think that our patients definitely can tolerate, a 25% potassium chloride with 75% sodium chloride. So I think I definitely recommend my patients, but I'd love to hear your thoughts and what you think about the study.
No, I agree with you. I think, like you mentioned, the public health impact of this trial is going to be large. I think as we progress into more time, having passed since the publication of the trial in the New England Journal of Medicine, generalizability again is always a question. If it's done in some of the other parts of the world, and how generalizable it is to the U.S. population or maybe the population living in the West. But I agree with you. I think it's a tremendous opportunity for both state and federal governments to institute policy changes and come up with guidelines as to what is permissible in terms of salt intake in processed food. Unfortunately, that is the kind of food that is readily available and is cheap for the population to consume. So I think if the overall prevalence of morbidity and mortality in the age group that was studied in this trial has to decrease and the burden of chronic disease has to decrease, I think this is a great intervention from a public health perspective. So I completely agree with you on that. I think translating it into, office-based practice for our patients, I'm sure you and I see patients like this in our clinics all the time. So the question for you is, Purvi, and I don't think I've used a salt substitute. So I'm going to ask you, what are some of the what are some of the brands that you're aware of that we can suggest our patients use, from a very practical perspective, in clinic, if someone asks you, okay, doc, now that the study is out, what do you want me to purchase from the grocery store?
Yeah, so the one that I have used is the new salt or no salt. And, I think, frankly speaking, I have to, go and look what exactly it contains. But that's the one that I have used. And I think it does have potassium chloride. I exactly don't know what is the percentage of potassium chloride in it. So I think that's what I have used. And, it's actually not bad. And, I think, at least in California, I have seen, patients, using that. I'm actually looking at the packaging and I actually don't see how much potassium chloride is in there. So I'll have to do some digging. But that's the one that I have used. And I'm sure that, there are others, but this is the one that, patients have tolerated. And I think I always also recommend use of seasoning, with spices and stuff, particularly given the cultural background that I come from and we are from. I think spices, herbs, seasoning definitely, leads to decreased salt use. And, that also works with, a lot of my patients that I see.
Yeah, no, excellent. Okay, so moving on, the next trial that you picked is the STEP trial. So do you want to tell us more about that trial, Purvi?
Yeah, so, just staying on the theme of hypertension. So STEP trial is again, a randomized control trial. It enrolled almost 8,500 Chinese patients with hypertension between the age of 60 and 80 years and randomly assigned them to either intensive hypertension treatment, which was defined as systolic blood pressure target between 110 and 130, and the standard arm, which was with systolic blood pressure target between 130 and less than 150. And it was very neat. The way they did it, they provided home blood pressure monitoring and they gave a smartphone-based application, and each patient would transmit the results through the application. So the overall results after, I think I want to say they had a median follow-up of 3 years, and the primary outcome was composite of stroke, ACS, heart failure, coronary revascularization, atrial fibrillation, or death from cardiovascular cause. So that happened in 3.5% in the intensive group compared to 4.6% in the standard group. So that leads to relative risk reduction of around 26%. And they also noted that 33% relative risk reduction in stroke as well as acute coronary syndrome within that intensive group with blood pressure target between 110 to 130. So I think that, this trial, if you, we had seen that with SPRINT, we had seen that the lower blood pressure in the intensive group, had been associated with better cardiovascular outcomes, except that there were some major tolerability issues. And I think that kind of got clarified in STEP trial, which definitely, had healthier patients. So I think that would this be applicable to our clinical practice? I think so. I think that, if you look at this trial, they actually, the mean age of the patients was 65 years. So I think we definitely have many patients in that age group that are relatively healthier. And I think that, of course, the target blood pressure of between 110 and 130, it's something that, we can at least inform the patient that the better the blood pressure, the better the outcomes, particularly in healthier population. I think the question remains, what happens when you take sicker patients, which almost, a lot of our cardiovascular patients have multiple comorbidities, and do we struggle then with, hypotension and, acute kidney injuries, etc. So I think one has to be careful, choosing the patients when going for intensive blood pressure control. But I think we do have a trial now that has, resolved that tolerability issue that came up with SPRINT.
Excellent comments, Purvi. And, thank you so much for comparing this with SPRINT, because that's the only other trial, of that magnitude that comes into mind. So, just discuss about the generalizability of the results. Again, this is, Chinese population. What do you think about extrapolating these results to, for example, South Asians, people from other, Eastern European ancestries, or, even people out in the West, whether it's, North America, including Canada and the United States, or some of the Scandinavian countries, or South America or Australia? I mean, what do you think about generalizing the results to all ethnicities? And the reason I ask this is not only because of its relevance to the globe and to the world, but as you're well aware, obviously you're living in California, so you're seeing diverse ethnic backgrounds and populations. And how do you sort of extrapolate these results to your practice and patients you see from multiple ethnic backgrounds and like a diverse patient population?
No, that's an excellent question. I think that, again, I think it's the phenotype that matters more here than the ethnic background, in my opinion. What exactly is the patient coming from? Because, again, these patients in this trial, at least, are relatively younger, and they're relatively healthier compared to, a standard cardiovascular patient that we see in clinic with CKD, diabetes mellitus, and other issues. Now, this trial did have, 19% patients with diabetes, which Sprint, I think, excluded all the patients with diabetes. So, and I think in this trial, they did have 6% patients with coronary artery disease. But I do think, I think it's interesting, right, Ankur? I mean, if we look at in general in a clinic population, I think the struggle is never, oh, you are 130, let's bring you back to 110. The struggle is always that your blood pressure is 150 and it goes, 10 times more than 150 in a week, and I need to bring that down, right? So I guess we just have so much to kind of achieve in this blood pressure range, right? Like, it's not that we have patients ready to kind of go from 130 to 110. Mostly all of us, we struggle with high blood pressure that are not at goal even by the standard guidelines, the conventional guidelines. So I think, in this trial, actually 33% of the patients in both the arms had average blood pressure of, I want to say, 138, less than 138, and they did bring those down. So I think that, would it be easier for us to go from our standard, blood pressure kind of targets to tell the patient that go down to 110 because your outcomes are better? I'm not sure. I think that we still have ways to go before we get to that point. But if you have the right patient who comes and, wants to have better outcomes and ask you that question, you have some data, is all I would say.
Yeah, and so in terms of intensive lowering of blood pressure, what are some of the go-to medications that you use? Like, we get this question all the time, right? Like, so I can tell you what I use in my practice. I mean, my usual go-to, I think, to start off with, I probably start off with a calcium channel blocker, dihydropyridine calcium channel blocker, and a thiazide combination. That's how I usually start my patients on antihypertensive medications. And I tend to use both these drugs in primary hypertension a lot more. Now, obviously, if someone has concomitant coronary disease or chronic kidney disease, if there's a history of stroke, I'll obviously go to renin-angiotensin or aldosterone system receptor antagonists. But if they're just primary hypertension, then the idea is to start them on amlodipine and, like a thiazide diuretic. That's how I practice. And my thiazide diuretic, the go-to, is chlorthalidone. But I'm curious to learn how you practice, escalation of antihypertensive therapy.
Yeah, no, that's an excellent question. And I think I kind of, my thiazide diuretic of choice is also chlorthalidone, because of the efficacy. But I guess, again, it comes down to, I see a lot of patients in the women's clinic, and I see patients with INOCA and MINOCA. And then traditionally, if you look at that subgroup, again, calcium channel blockers are great medicine, particularly diltiazem. And I do use ACE inhibitor again for that endothelial effect. And, there have been some small studies in women. So I guess it all depends on who are these patients, that you are seeing. But yeah, primary hypertension, I completely agree with you with the standard, approach with diuretics and calcium channel blocker. I'll most never use beta blocker. Now it is also not favored by guidelines. And then, depending on what they have, albuminuria or CKD, then I would add an ACE inhibitor. And, but yeah, I mean, I guess in cardiology, we don't get to see those primary hypertension, essential hypertension patients that commonly. I see mostly women that are suffering from INOCA and MINOCA. So I've modified my practice accordingly.
So the next one that we are going to discuss here, I think Emperor Preserved is a landmark study, and for many reasons. But I'm not going to steal the limelight from you. I'm going to talk us about the Emperor Preserved study and the implications it has for patients that belong to a very difficult bucket for us as cardiologists.
Yeah, I mean, finally something, in the heart failure preserved ejection fraction, subtype. So yeah, Emperor Preserved, it randomized almost 6,000 patients with NIHA class 2 to 4 heart failure and ejection fraction of greater than 40% to empagliflozin 10 milligrams once a day or placebo, both on top of standard therapies. And this was studied at 622 centers in 23 countries. These patients were required to have a GFR of more than 20 and higher along either the structural heart disease, which was I think just dilated LV or dilated left atrium, or a heart failure hospitalization within the past year. So almost 49% of these patients were diabetic, but almost half of them were non-diabetic. And 45% women, a mean ejection fraction was actually 54, and mean age of the patients were 72, and almost 82% of the patients had NYHA class 2 symptoms. So the primary endpoint was a composite of cardiovascular death and hospitalization for heart failure, and that was reduced by 21% with the SGLT2 inhibitor, which here it was empagliflozin, with a number needed to treat of 31. Now, this was driven by a reduction in hospitalization. So the first heart failure hospitalization decreased by 29%, and the cardiovascular mortality, which was not significantly reduced, it was 9%. So basically the driving part of primary endpoint was the heart failure hospitalization. And I'm sure you caught some lot of roar on social media about this, and why the kind of study was a bit criticized, because mostly the primary endpoint was driven by heart failure hospitalization. The secondary endpoint was recurrent heart failure hospitalization, and that was reduced by 27%. Also, the GFR slope was almost half by empagliflozin, versus placebo. So I think, as you correctly pointed out, this is another, practice-changing landmark trial. I think that there have been, so many investigations and trials that were done in, different study groups before this, and finally we get something that was that's positive. I think that this is definitely going to be practice-changing. I think that we all see these patients in our clinic, in our hospital, and, now there's something, we always, I don't know, whenever I talk to my fellows, I always told them that I don't understand heart failure preserved EF. And there is no medication. And finally, I think, as they pointed out during the presentation, this probably will translate to change in the guidelines, although the ESC heart failure guidelines was, were presented during this session. So probably, probably another update will come out in those guidelines. That's at least what the presenters indicated. So I think this is very applicable in our day-to-day practice. I think that if you take, overall, the patients that they recruited, was more than 40%. And if we look at the pooled analysis that was presented during ESC again, that kind of combined the patients participating in Emperor Reduced and Emperor Preserved. Again, both the trials have this consistent efficacy when it comes to heart failure outcomes. And so there was almost a 30% reduction in the hospitalization across a range of the EF from less than 25% to less than 65%. And then more than 65%, they observed this attenuation effect But if we look at the same group, the effect of the empagliflozin was way greater than what was observed with Entresto in Paragon HF. So Paragon HF was negative, but the effect that it had, the empagliflozin was way greater. And then, this effect of when they did the pooled analysis, the effect on the renal outcomes, however, was different between the two. So Emperor reduced had shown reduction in more than 15% decrease in GFR and renal death, but Emperor preserved wasn't significant for that. So again, what does it come down to? I think that yes, they took patients of now what is classified as heart failure, mildly reduced EF between the 40 to 50%, and then more than 50%. And we traditionally think of heart failure preserved EF as more than 50%. So they did combine both these groups, but I think it still is. I think it still is applicable because I think that basically more than 40% EF right now. This is how the guidelines tell us. There's not much to go by, and I think that this medication definitely adds a lot to the existing literature, and I think that we all are going to use. And when it comes to more than 65% EF patients, I mean, if you think about it, if you take more than 65% EF, and if those patients have diabetes, you already have a indication to prescribe SGLT2 inhibitors. And more than 65% EF and no diabetes population, that's the only population that probably remains where you're not going to prescribe it. But otherwise, this is, very much, this is very much applicable to the clinical practice. I think the presenter had suggested that they're going to have this further analysis of the EF groups at AHA. So that would be very interesting data to look at what exactly happens when you take 40 to 50 and then more than 50% EF. So overall, practice-changing medicine and totally a win for our patients.
Yeah, I agree with you, Purvi. So in a really vexing patient population, like you've suggested, no medication has worked whatsoever. And some of the other earlier SGLT2 inhibitor trials which were published in the New England Journal before Emperor was presented at ESC, showed that there may be a reduction in heart failure hospitalization with this particular class of drug. And now we have a definitive trial. And thank you so much for going over the percentages of primary endpoint reduction and secondary endpoint reduction. I think those would be extremely relevant when we discuss this with our patients. So my question to you is, look, we see these patients all the time in our clinics, and, they comprise 50% of the overall heart failure cohort of patients. So are you now going to start prescribing these patients empagliflozin 10 milligrams once daily as you see them?
Ankur, it's interesting, but I actually had started prescribing these patients, the medicine. I don't know when the first, both Emperor Reduced and DAPA HF, these medicines, if you look at it, like the way they work, the impact they have on our, overall physiology of the body, I really believed in these. And I do think that these are going to be statins of tomorrow. And, there's talk of having them in, water. And I totally agree with that. I think for diabetic patients, like I didn't worry about, what happens to the creatinine. I have to watch out for hypotension. The data is so strong that I was prescribing. There was a lot of debate about, who's going to be prescribing? Is it going to be the nephrologist? Is it going to be primary care? Or is it going to be cardiologist? And I go to a community health center here, and I do clinic with my fellows. And, I have been very aggressive in prescribing this medicine because I totally believe in this, class effect And I totally think that this is going to be the game changer. It already has proved to be a game changer, but I just cannot wait to see what comes out further out of this. I also put my parents on this, by the way. My dad met indication. So I'm a firm believer in SGLT2 inhibitors, and I will continue to prescribe it. Yes.
Yeah, no, likewise. The only reason I brought this up is that, in my practice, with other colleagues at least, and I see a lot of inertia still around prescription of this drug class. They're like, it's a diabetic drug. You should have an endocrinologist prescribe it. Should be, like I said, have a nephrologist prescribe it. If you look at the recent prescription patterns, actually, the prescription, and these are from some of the industry data from AstraZeneca at least, and AstraZeneca is by no way, shape, or form the sponsor of this episode. Just putting it out there. But some of the industry data that I've looked at have actually shown that the prescription is slowly increasing among cardiologists, and it's sort of considered the cardiology heart failure clinic drug and not an endocrinology clinic or a nephrology clinic drug. So I completely agree with you.
I think the major inertia in cardiology, I agree with you that there is inertia, and I think that comes predominantly from this fear of side effect that, this is a new medicine. What am I going to get myself into? Do I have to follow that creatinine? Am I going to watch this patient for development of diabetic ketoacidosis? What is going to happen to the sugar? What's going to happen with the UTI if they develop UTI? So, but, overall, I think the safety and efficacy, it's pretty good. It's not as common to observe any of those things that I just mentioned. And I think that's where the inertia has come from. But, once you start prescribing, you realize that it's actually easy medicine to maintain. And I think we saw a similar pattern even with Entresto, right? People were fearful. I remember I being fearful of prescribing Entresto, if I'm going to miss something. But now, as the medicine is in market and we order more and more of it, I think we just become comfortable. Don't you think that that's the predominant reason for cardiologists to have that inertia?
Yeah, I agree with you. It's funny you mentioned that, but it's true, because I think the one thing cardiologists do not want to manage is Fournier's gangrene, which was unfortunately was advertised. It occurs. Don't get me wrong, and I think it's important to be aware of it. It's important to be educated about it. But you're not going to see Fournier's gangrene on every patient you put on an SGLT2 inhibitor. So, and just the data are so ironclad, and, like I said, the class effect is profound that, particularly, and before Emperor Preserved was presented, the number needed to treat for a quadruple backbone to prevent one mortality is 4, so the data are super strong. And, if cardiologists can prescribe aspirin like water, and aspirin, as we now know, from the 3 primary prevention trials, is not as benign of a drug as we initially thought it was, then, and aspirin has a higher NNT than, the SGLT2Is as quadruple backbone. I think we should not be taking this life-saving therapy away from our patients. So I agree with you. So moving on. So the next trial that you've picked is a very interesting trial. And again, it may not be practice-changing for a lot of us, but it certainly is very practice-informing. And that is the LOOP trial. So you want to go over the rationale and the design and the results of the LOOP trial?
Yeah, of course. So as you correctly pointed out, it's the practice informing, because now with Apple Watch, I'm sure that you're getting all those, consults in clinic and, of patients coming with these strips of arrhythmia, showing arrhythmias and AFib that their Apple Watch have detected. So I think this was, really informative trial. So this was performed at Danish centers. They recruited around 6,000 patients between age 70 to 90, almost 47% women. Patients had risk factors, predominantly either hypertension, diabetes, heart failure, or previous stroke. And they were randomized 1-3 fashion to ILR monitoring, which was Reveal Link by Medtronic. And again, not sponsored by any company here, but that's what they used, or standard of care. 90% of the patients had hypertension, and almost, I think the median CHA2DS2-VAS score here was 4, and they were followed for almost 65 months. So as any of us can imagine, AFib was diagnosed more in the ILR group. I think it was 32% versus 12%. And I think the median duration of monitoring here was 39 months. And then, of course, the patients that were diagnosed with AFib were likely to get oral anticoagulation. So the rate of anticoagulation was also higher in the ILR group. So that was 29 or almost 30% to 13%. But however, this increase in the AFib and increase in the oral anticoagulation, it didn't translate into a lower risk of stroke or any systemic embolism with ILR versus the standard care. And also there was no difference in all-cause mortality, cardiovascular death, or major bleeding. So I think this is, AFib is the most common arrhythmia that we see. We all know that AFib can be there when patients don't have symptoms, and we know that there are a lot of patients remain undiagnosed, and I know that I am very aggressive when it comes to detection of AFib because I do think that stroke is a disabling, disease to have. And if we look at the guidelines, European and US guidelines both recommend screening for AFib for patients that are 65 and or older with a standard EKG when they come to your clinic. And if they have risk of stroke, then more systemic and aggressive intense screening. So I think that this question comes out all the time, right? Like you have a Holter monitor or Loop or any other monitor that shows AFib for a brief period, and what do we do about it, right? And some of us are more aggressive than others, but basically that's the answer that this trial gave us. So almost 50% of the strokes we know that are linked to AFib. And if we take the cryptogenic stroke, almost 30% of them have underlying AFib. So we know that we detect, more AFib when we put any sort of monitor on the patients. And, Ankur, what was interesting is that at the European Heart Rhythm Society meeting earlier this year, they presented Stroke Stop trial, and that actually had screening via intermittent EKG reading taken twice a day for 2 weeks, and that trial was positive. So they had a longer follow-up of almost 7 years, and this was longer than Loop. But they had a significantly lower rate of primary composite. I think it was stroke, systemic embolism, bleeding, and all-cause death. So it was one trial that was positive that was, I think, published recently in Lancet with a longer follow-up and with EKG, intermittent EKG readings, done twice daily for 2 weeks. Versus another trial, which is with Loop, shorter follow-up and negative study, right? So I think that what matters is, what exactly is the significant atrial fibrillation? And I would think that if you are able to detect atrial fibrillation randomly through the day, on an EKG, you probably have that atrial fibrillation for a longer than 6-minute period, because that would be very odd to pick just randomly AFib that is just happening for a brief period on an EKG. So I think it's a type of the AFib, stroke stop picked up, which probably was more clinically significant, more longer in duration. And of course, they had a longer follow-up, and that's why probably that trial was significant versus Loop was not significant. So I guess we are not going to be worried about, that subclinical AFib that gets detected. At least now we have some data to inform our patients and kind of, give them that, the good news that it probably doesn't matter if you have brief AFib detected on your Apple Watch versus, the longer duration. So.
Yeah, no, I think I'm in complete agreement with, and, by the way, thank you for bringing up Stroke Stop, because Stroke Stop was not presented at ESC, but was sort of published in Lancet while ESC was happening. And, the loop was presented at ESC. You hit the nail on its head when you said that Stroke Stop was twice daily EKGs. For 2 weeks, longer follow-up. Loop was continuous monitoring, shorter follow-up. The cutoff was 6 minutes for Loop. And, what is the likelihood of you picking up AFib on 2 EKGs, in a 24-hour period? You're probably going to have much more than 6 minutes AFib burden. I think the message is sort of synchronous. I think if you put the two studies together like you did, that is, if your AFib burden is longer than 6 minutes, it's a better idea. I mean, Stroke Stop didn't really quantify the burden of AFib, but if it's longer than 6 minutes, or if you have a higher AFib burden, I think, and with the requisite risk factors that we know of that predispose one to a higher risk of higher annualized risk of stroke from AFib, stroke being a disabling disease, like you mentioned, better off being on an anticoagulant. And we've got very potent, very safe anticoagulants. So just be safe and prescribe your patients anticoagulants if the burden of AFib is higher. But again, like we mentioned at the beginning of our discussion, practice informing trials. So with that, Purvi, I think we're going to end with an important public health message. We started off with a public health trial. We're going to end with a public health trial. And before I begin with influenza vaccinations, I think it's an important public health message to everyone. I mean, the vast majority of our listeners are physicians and cardiologists, but it's ridiculous to see that even amongst physicians, there are some who believe that vaccination is not the way to go, and it befuddles my mind to even think that there may be physicians who think like that. So I think it's important to get vaccination for COVID, folks. I think Purvi would probably second that message. I just wanted to use the platform of vaccination and IAMI, to sort of, deliver the message on COVID vaccines. But I'll have you sort of resonate that message and sort of talk about IAMI trial then.
Yeah, no, I think it's very unfortunate, the hesitancy that we see within the physician group. And I guess it probably comes from, all this preconceived notion that we have before we go to med school and before we get our degrees. I guess that kind of remain ingrained as we go through our degrees, right? And, I don't know, the way the issue has become so politically charged in the United States. It's unfortunate. And I think, I don't know if you saw my social media story yesterday, but it's kind of sad that, there is something now that is 100% preventable in a country like United States, and we are still struggling with this, and we are seeing kids and we are seeing young individuals, suffering, dying because of this condition that is 100% preventable. So couldn't agree more with you. And I hope that this trial, as we talk about it, it'll make people more aware of the advantages that come with vaccination, and particularly with COVID vaccination, since we are still, in this pandemic. So IAMI trial, they unfortunately were actually halted early because of COVID-19 pandemic, but they managed to enroll, I think, 2,500 patients or 2,500 patients, which was 50% of the population. 58% of the population they had expected to enroll. They randomized these patients in 1-to-1 fashion to receive either influenza vaccine or placebo within 72 hours of cardiac catheterization. or hospitalization. So they included actually patients with STEMI and STEMI, high risk PCI, CAD admissions, etc. And median age of patients here was 60 years. Low women, 18% were women. Primary endpoint was composite of all-cause death, MI, and stent thrombosis at 12 months. And they also tested the secondary outcome of all-cause death, cardiovascular death, MI, and stent thrombosis in a hierarchical by using a hierarchical testing strategy. So the overall result found that the primary outcome had occurred 5.3% patients in the vaccine group versus 7.2% in the placebo group. So really, really glorious 28% reduction in the primary endpoint. And, when we look at the secondary endpoints, rates of death from any cause and cardiovascular death were lower in vaccine group compared to the placebo group, with a very impressive reduction of 41%. So also what was interesting in this is that they did not observe any difference in the rate of myocardial infarction with either of the groups, right? So we don't know by which mechanism, the influenza vaccine works, but it clearly works not just in preventive cardiovascular death, but also, death from any cause. So I think if we look at the big questions, I think these patients, I personally think that they chose a really good period, taking those patients with, STEMI and STEMI, they come to the hospital, they're probably mostly there for 72 hours. They chose that period. Within 72 hours, they gave the influenza vaccine, although it was in influenza season. So some of the important questions we ask is that, can this be applicable all year around? Because we know this is not the only trial. Before this trial, there have been multiple small randomized control trial and the observational data that show that, influenza vaccine is beneficial, although this is the largest trial to date, as far as I know. So I guess the question is, can we give influenza vaccine all year around in our cardiovascular patients as they come for the, with ACS? And then, the other thing is, what is, as a cardiologist, what is my role, right? So I think that right now, at least we don't give influenza vaccine in cardiology clinic, but is that something that we should embark on in our, in general, in cardiology practices across the world? And also, the other thing is that, can we know that there was some data with influenza vaccine as well as COVID vaccine taken together, and it was synergistic and positive. But can this be done together? And, what does the futuristic plan look like, and who's going to give this? Right now, if we look at the ESC and AHA guidelines, it's a class 1B indication already. So should we embark on this journey and also start giving our patients influenza, since it is going to prevent those cardiovascular deaths? So we'll see, what the future looks like. But for now, we have a very strong data from a study that could not be completed due to COVID fully, but still with, really glorious and impressive results with a clear reduction in cardiovascular as well as all-cause mortality.
Yeah, no, excellent message there, Purvi. I think, as a routine, I would ask patients when I would see them in clinic during the flu season as to whether or not they've had their flu shot. And I've been doing the same for COVID-19, and, sort of being a proponent for, sort of influencing them to get the vaccine, sort of doing my part as a good citizen. I think the time is upon us, right? When the flu season hits, and I'm probably going to do the same, just say, both the flu vaccine as well as the COVID vaccine. Vaccination is important. Vaccination saves lives. So that's what I'm going to do. And, now I have a trial to support my hypothesis. So Purvi, thanks again for this. This was just a fire hose of knowledge and information, and you did an excellent job in going over the data and explaining the rationale of all these studies, how they would impact our practice. Any closing thoughts or remarks for our listenership?
I think, no, thank you for inviting me. I think that, it comes down to how much we apply all this knowledge into our clinical practice and how we change our lives of our patients. So I hope that, it was useful to the listeners. And thank you again for inviting me.
Oh, my pleasure. This was incredible. Thank you for doing this for us at such short notice.
We hope you enjoyed today's podcast, produced by Radcliffe Cardiology in association with makeadent.org. We aim to bring you a new angle of all things cardiology every second week. Review us on your favourite podcast app or send your comments or questions to podcast@radcliffe-group.com. To view the series, head to radcliffecardiology.com/podcasts/Parallax. Thanks for listening.